Good morning, everyone. Well, I'm a little different from the crowd. I'm a plastic surgeon, and enlightened by this opportunity that I get to work with my colleagues here and present it here. So, this is the hospital. So, luckily, we are just a few blocks, a road end away. So, it's easy to go down to LVPI and then do the procedure. As plastic surgeons, we routinely handle nerves, and nerve reconstruction is a routine part of the armamentarium. And I'll just take you back a little bit to the anatomy. And when we see in the histology, so the nerve structure consists of, when you see the nerve bundle, any nerve bundle has a complete outer layer covering, that is the epineurium. And once you open the epineurium, you see several fascicles, which are actually groups of axons. So sometimes when you have, say, a nerve to the hand, in fact, one fascicle goes to the index finger, one fascicle goes to the thumb, one fascicle goes to the middle finger. That's how the topography has been designed by nature. And each fascicle is surrounded by a perineurium, and you have an endoneurium. This basic anatomy, and there are Schwann cells you can see. This basic anatomy is important for us to understand the principles of nerve repair. The gold standard is avoid a tension-free coaptation. Any nerve that is sutured under tension will give way, and you won't know the result. And whenever possible, we try to use end-to-end coaptation, whenever feasible. But if end-to-end is not feasible, there is no harm in using a bridging nerve graft. When you do an end-to-end repair, it's just one coaptation that the axons have to jump through, and the results are very good. And when you have a nerve graft, there are two junctions at which it has to jump through. There is always a number of axons that have passed and reached the final target is always around 2/3 of the original donor material. And the nerve graft is not going to really function or anything. It's just a conduit. It just funnels the entire axonal input into the effector organ without letting it go sideways. So these are the basic principles of nerve repair. And this tension-free coaptation is obtained by means of suturing only the epineurium to epineurium. Because if we go deeper, we have a high chance of injuring the axons. So we don't know what the result will be later. So this is we as plastic surgeons and all that. So the human body has two eyes, and there are great experts to take care of the two. And the third eye that we consider is the hand and the foot. So with the hand, we can really identify if there's a hard surface or if there's a soft surface and everything, if it is hot or cold. So that is all possible because of the nerve input into the hand. So this is a trauma case where there was a wrist cut injury and the ulnar nerve has been transected, and neurotization goes back to quite some history. And we have done an end-to-end repair with 8-ethylon here because you require a stronger suture. And by doing this, the nerve is going to grow from here into the hand and restore the sensations back in the ulnar nerve territory, which is this border of the hand, which is very important because when you touch anything, that is the first thing that rests. So whenever end-to-end is possible like that, we do end-to-end. So this is a patient who had a stab injury on the base of the thumb, and that was left, and she ignored it, and she had loss of sensations there, just like our insensate cornea. So we explored the wound, and we found that the radial digital nerve was in continuity, whereas the ulnar digital nerve, there are two digital nerves to the thumb, was transected, and there was a small scar neuroma as well. So there is no way that sensation is going to come back into this. The only way is to neurotize it. So when we cut the neuroma here, we are expecting a gap. And if we try to suture the two ends together under tension, it's going to break down, and we are not going to have the result of the sensation coming back. So this is now after complete isolation, and we probably have around a 2 centimeters nerve defect, and there's no way this is going to come together. So the only option is to use a nerve graft. So the nerve graft, there are various sites, but we chose the sural nerve graft. So this is an interposition sural nerve graft that is interposed between the two nerve endings, and once it is interposed and sutured with ethylon, and we strengthen our coaptation with some nerve glue. So instead of pouring it, we try to get the fibrin made and then deposit on top of it. And by putting this, we expect the sensations to come back. So, what are the different sites from where we can take a nerve graft? Because nerve grafts are essential, we need to take them. Ideal donor site should be a sensory nerve, because you don't want any motor deficit. Suppose you take a muscle nerve graft and then muscle undergoes palsy. So, therefore, that is not expendable. We need a sensory nerve, and it should be expendable. So, we can't take a sensory nerve from a very important area, say, such as something that is from the hand or anything. So, we want it to be an expendable donor site. So, that is why the sural nerve is taken. And so the examples, and not only that, it should be long enough and adequate, because we are talking of targets around 7 to 8 centimeters away. So various examples are sural nerve, and as Dr. Smriti had shown, auriculotemporal nerve, which runs at the posterior border of the ear, and lateral cutaneous nerve of thigh, and etc. And we choose depending on the area. So the auriculotemporal nerve, we can use it for parotid surgery because it's contiguous. Whereas for corneal neurotization, so our choice is sural nerve. So this is a sural nerve. This is a sural nerve graft harvest plan, where this I've marked the lateral malleolus here and the head of the fibula here. So posterior to the lateral malleolus, this is where the sural nerve runs. So the sural nerve supplies sensory distribution to the lateral border of the foot, as well as the fourth and fifth toes. And this area is somehow not really is quite expendable, because as in our country with wearing chappals, the most important point of sensation that we want is between the great and second toe, because to wear the chappal and to fit it there. So this is quite expendable, and we as plastic surgeons routinely take around the entire length, 40 centimeters, 35 to 40 centimeters of sural nerve, and both legs, because we require it for brachial plexus reconstruction, for multiple nerve reconstruction. So it is safe, proven technique. And instead of making a very long longitudinal incision, so we make multiple short incisions through which the sural nerve is easily identified in the subcutaneous plane, and then you take it. And it is done under tourniquet control. So that's why, as Dr. Smriti had shown, there is a nice avascular field. And the tourniquet does have its own limitations, because you need to be very careful in applying the tourniquet and deflating it, otherwise it can lead to permanent limb ischemia. So we prefer multiple small incisions, and not try to avulse the nerve, and try to keep it, try to preserve the branches. And regarding the direction, as well as sir has asked, so the distal end of the sural nerve tends to branch into a calcaneal and a sural branch. So the distal end is naturally branching. So we can actually keep the distal end towards the cornea, so it decreases our dissection, so we get more fascicles, more branches much more easily. Whereas the proximal one tends to be a common bundle, which can coapt to the supraorbital and supratrochlear nerve. So once the nerve, so this is the patient who has been planned for corneal neurotization, and as soon as I see this, so this is the right side that is affected. So my plan was, so the feeling that we get is, what is the donor? So the donor is the opposite side supratrochlear nerve, so which we have marked here. So so we check the sensations all right, our donor is good, and then this is our recipient. So there are multiple donors that we can choose. We have the supratrochlear, supraorbital, infraorbital. So infraorbital would run from here. We choose the supratrochlear and supraorbital because this area sensations are expendable, whereas if the infraorbital is taken, we compromise on loss of sensations to the upper lip, which is pretty important, especially when sipping hot fluids and everything. So the decision is made, opposite side supratrochlear for indirect, and this is as previously shown. So the nerve graft that has been harvested. So through here we have isolated the normal side supratrochlear and supraorbital bundle, and this is the nerve graft that is being tunneled. The amount of nerve graft that we take is, we measure from here till the limbus. So usually that translates to around 5 to 6. We keep around 2 to 3 centimeters extra and use that amount of nerve graft. And we don't tend to take more because it can be preserved back at the donor side. So once the nerve graft is tunneled through it, and here we can see that the supraorbital and supratrochlear nerve, they are very flimsy. So sometimes they don't tend to be very bulky. So we may need to do an end-to-end coaptation, because by doing an end to side, the amount of fascicular or axonal input is going to be pretty small. And from here through the opposite minimal incisions and through that tunnel into the eye, and so we have our proximal end there. What I'm holding with the left hand is the supraorbital. So this is the contralateral supratrochlear and supraorbital nerve bundle together, which itself is barely matching the sural nerve. So the nerve coaptation, this is the proximal nerve coaptation. We can do either proximal first or distal first. So if you do the proximal first, you can trim away the excess. So you can try to minimize the length of the nerve graft as minimum as possible. Because after coaptation, there is a temporary pause period of around 28 days. And after that, the nerve ends start growing through the coaptation. And the traditional way, what we see in hand is the recovery is around 1 millimeter per day. So in approximately 90 days, we are expected to move around 8 centimeters. So that means we have reached the target. So around 3 months later, we can expect some amount of axonal input into the cornea. And once the input is there, it has to go into the effector end organs, and that only gets better and better with time. So like here, the final step into the limbus. Once we try to put in as much axonal input as we can through this, so that the amount of recovery is at its highest. Because anyway, we have sacrificed a donor nerve there. We want everything to be channeled to this. We don't use a motor nerve for input, because classically the motor nerve input is not going to match, because we predominantly want only sensations. And neuratization is a time-tested proven technique in other parts of the body, like hands and sole, where we routinely use multiple nerve grafts and everything, and patients do get back not only sensations and even motor function of the hand. So it's very interesting that we get sensations back at the cornea. So the patient, and a natural healthy nerve ending produces its own nerve factors, growth factors, whatever its milieu that it wants, rather than what we want to supplement. So it's going to restore it's not going to function for one day, but keep on functioning till the end of the life. Yes. Thank you. Yes. Allografts are an option for people usually publish allografts for small digital nerve gaps, where instead of taking an autograft, it is readily available off the shelf and everything. Personally, I've never used it, because we know that autograft, the donor site morbidity is so minimal, and we can get it so quick, and the results are guaranteed. So autografts work excellent. Maybe in situations where suppose hand transplant is going on, and you definitely have a paucity, so because you need multiple cables for median, ulnar, radial, in such situations I think allografts will have their role, and they have been using them, but personally I do not have any experience with them.
So are they available in India? Do we have tissue banks that process these from
No,
donors?
I have not heard of any nerve bank till now.
Okay.
That's a good idea.
The allografts require some kind of rejection or something like that.
Yeah, that is a risk. So usually they try to decellularize it and preserve only the tubule, so that the antigenic reaction is kept at its bare minimum. So it's something like we have alloderm that is commercially available, where it is decellularized dermis. So something like that, without its Schwann cells and everything. But given an option, autograft, I would definitely choose autografts, because the donor site morbidity can be explained to the patient. And with adjacent creeping sensations, the loss of sensations is only temporary. After 6 months to 1 year, you see that the adjacent dermatomes overlap, and they no longer complain of that paresthesias on the lateral quarter of the foot.
Final question, maybe slightly stupid. Like all plastic surgeons are well versed in denatization.
Yes.
So it's not something that you require a special training or something.
Yeah. In fact, we take around 35 to 40. So it's in fact much more happier and easier for us to stop at 7 to 8 centimeters of nerve graft. And the coaptation is not very easy. So we need to make it, because unlike a vessel repair, you do a vessel repair, the result is immediate and apparent. If it blocks, on table, you can revise it. Whereas nerve repair, you need to wait at least 6 months to see your result. And if the coaptation is not proper, and if it has moved away, 6 months later, you just can't do anything later because you have lost a potentially the most valuable donor nerve, and it has not got. You need to wait 6 months for your result, and you can't go back.
Possibility of using cadaveric
Yeah, that is the allograft that we were discussing. So allograft we have not used till now, and it is an option probably in multiple where you require multiple nerve grafts. So, and there is you don't already sural nerve is used up or anything like that.
I think the technique of that you used putting the fibrin glue was very good, because I think I learned from you during the last couple of cases that we did together. So the way of putting both the fibrin and the thrombin together and making a blob probably kind of secures the graft instead of putting one after the other.
Yeah, we are very scared of nerve coaptation because the
Yeah.
result is not apparent, and we try to secure it as much as possible so that we should not fail, because you just get that one chance. So I actually saw that technique from the Terzis. Julia K. Terzis is a plastic surgeon herself. So she was doing this, and I saw in one of her technique where by making that glue, it feels more secure, and you need to put less number of sutures. So
Thank you.
same glue that we use.
Yes.
Yeah.
yes,
Releasing or Baxter.
Baxter.
yeah, Baxter.
Rajesh, this end-to-end versus end-to-side, when we do that at the supraorbital, what's the difference? Like, is it a delay in the time taken by the nerve to grow, or is it that the spread also will not be that great if you have end-to-side?
When we choose the proximal
Right.
donor nerve, I think we will need a caliber that matches the sural nerve. So if we find the supraorbital and supratrochlear bundle to be pretty bulky, and it is almost up to the caliber and little larger than the sural nerve, maybe end to side coaptation may be better, because then you can make a good nick in the epineurium and do some controlled axonal injury. But if the end is already very thin and flimsy, then maybe better to do end to end.
End-to-end.
So how do you ensure when you're doing an end to side that those fascicles actually go into that conduit that is on the side? So end to end, it's like given
Yeah.
that they just go directly. But end to side, what do you do? Do you cut a bit of the perineurium of the most adjacent fascicle, or what? It's
Yes.
like-
So people say only epineurial window, but definitely there is, you incise the epineurium, and some amount of axonal injury is created. Only then, so probably if you have a nerve with around 3 fascicles, you can sacrifice one fascicle, and then so that this fascicle, instead of growing distally, it will grow distally, it will also grow to the
also go
sideways.
on side.
So there was a lot of debate on whether this will really work or not, because what if it doesn't grow sideways and grows entirely straight? But again, it has been time tested, because we use it in brachial plexus, where we use the ulnar nerve as a end to side to the nerve to the biceps, and it recovers. So even the ulnar nerve is kept in situ, and the biceps function does recover. So it is, with time we know that it will work.
So even the supraorbital part is also sutured by the plastic surgeon. The end to end.
Yeah.
Yes.
Yeah.
So now you all are doing
We both do it, and it's done under microscope. Just like fortunately, we have those sutures, the ones which they use for vascular and nerve repairs.
So it's all team effort. So unless the team comes together, only then it makes the entire effort very simple, and patient gets 200% out of it.
I think that's of the whole thing, to have a team from
Correct.
different organizations.
No, so at the end of it all, the plastic guys were like, oculoplastic guys, like, no, we can do this whole thing. We don't need you or them.
I think if you just do it once or twice, you feel that sural nerve harvesting is easy and you can do it. But then there have been cases where suddenly there's a deviation in its track, and that's when their experience comes in. So even if you know how to do it, it's good to have them for deviations, for complications, for problems.
Yeah, and I think we've seen variations in the anatomy of the sural nerve where
Yeah.
it's very, very thin, and then we would have been at a loss as to how to proceed
Right.
further.
Sensory nerves and sensory nerves are very diverse. Like they're not specific that they're going to be there, so they can have a lot of variation. So initially, it just gets a few cases to get the hang of it, because suddenly the most confusing thing is the vein is isolated instead of the nerve, especially
Yeah.
under tourniquet. and you only realize it once you have detached it and removed it. So the vein is not going to work, and it's not going to make it. Obviously, when you see under the microscope, you'll see a lumen, so you'll discard it. So just a few cases of the hang, and medicine is all about overlapping fields. So everything, ultimately, the benefit goes to the patient.
I think the length of the nerve that you get onto the eye also, you should make sure it reaches all around the limbus. So I remember a case that I was doing where we didn't realize preoperatively that this patient actually had subconj fibrosis. So there was a nasal aspect where I could not dissect subconjunctivally adjacent to the limbus, and I had to take a fascicle all the way around the fibrosed area because I could not separate it. Otherwise, I had to go around that, and then kind of anchor it. So I was able to get only 3 tunnels into the cornea and put the fascicles in. So I think pre-op evaluation also, maybe Murli might highlight that when he's talking. It's extremely important to understand all those nuances too.